Good morning, everybody. Good afternoon, good evening, wherever you are. I am Moshe Mittelman from Tel Aviv, and I'm very glad to be here with you, although I'm sorry that it has to be virtually. Hopefully next year, it will be face-to-face. These are my disclosures. So I would like to start with presentation of patients, which will probably show us the problem. Mr. OS was 63-year-old when first he presented in this is Mrs. OS. She was 63-year-old when she first presented in 2012. Routine blood count showed mild thrombocytopenia, 60,000. She was asymptomatic at the time. Past medical history was remarkable for stable ischemic heart disease, physical unremarkable, very mild anemia, nuclear ANC 2000, and she was diagnosed as having lower risk MDS. Over the years, she was followed. There was a gradual platelet decline, but she remained asymptomatic with minimal subcutaneous hematomas that did not require treatment. Recently, platelet count was 25,000, but she developed atrial fibrillation, and the cardiologist recommended anticoagulation. Mr. TK was 79-year-old when he first presented about 10 years ago with mild anemia and thrombocytopenia. He was diagnosed as having lower risk MDS. Past medical history was remarkable for hypertension, diabetes, ischemic heart disease, and he underwent at least 2 cardiac catheterization. Over the years, he experienced a progressive disease. The anemia became transfusion dependent, he required DSA, then he developed or transformed into higher risk disease, requiring azacitidine with some kind of response. Over the last year, he has been on transfusions, platelet transfusion, red blood cell transfusions, and supportive treatment only. His ECOG status is still high, 0-1, very active, functional, but anemic and severely thrombocytopenic, less than 10,000, although no bleeding. Recently, he has had some symptoms, was investigated, and was found to have active angina syndrome, as well as severe aortic stenosis, requiring PCI, cardiac catheterization, as well as TAVI. He underwent these 2 procedures, but the cardiologist insists on clopidogrel and aspirin, or at least one of them, with the platelet count of less than 10,000. Mr. IR was 73-year-old several years ago when he presented with mild anemia, almost asymptomatic, diagnosed low-risk MDS, past medical history remarkable for hypertension, which was at that time controlled. He was so stable that even lost for the follow-up, and I didn't see him for several years. Few months ago, I was called by the neurology department. He was admitted with transient ischemic attack, which was transient. The platelet count was 42,000, and aspirin was recommended. So what's the problem? Thrombocytopenia is relatively common in myelodysplastic syndromes. Severe thrombocytopenia is less common. Severe thrombocytopenia less than 30,000 is in about 5 to 20% of the patients. The bleeding can be due to the low platelet count, but also due to platelet dysfunction that has been shown in several studies, including ours. Hemorrhagic complications can occur in 3 up to 50% of the patients, and this was reported in 13 to 24% of the patients. Other consequences that we might take into consideration are the need to avoid anti-MDS treatment because of the thrombocytopenia, sometimes such as lenalidomide or AZA, and again, the problem that we are dealing today with the need to use anticoagulants or antiplatelets in patients with cardiovascular diseases. It has also been shown to be associated with poor prognosis, AML transformation, and short survival. We also, in the European MDS group, the first author was Rafa Isaacson 3 or 4 years ago. We published and we proved that even early platelet drop, the platelet dynamics, is also a poor prognostic factor. So in these patients who need antiplatelet or anticoagulation, the problem is even more severe. We have agreed that thrombocytopenia is common in MDS. Cardiovascular disease is common in this elderly population, and the indication for anticoagulant and antiplatelet therapy is often encountered. The problem can be even more complex because thrombocytopenia might be associated with bleeding, but on the other hand, one should keep in mind that the thrombocytopenia does not protect against thrombosis. Individual platelet count is often very poor predictor for bleeding, and other comorbidities make our life and patients' life more difficult. The problem is even more various and heterogeneous because if we talk about anticoagulation, we might talk about temporary treatment for acute VTE or chronic treatment supposed to prevent stroke in patients with chronic atrial fibrillation or to prevent recurrent DVT or TIA or stroke, and this is a chronic permanent use. Antiplatelet treatment also can be long-term in cardiac patients or can be transient, and we talk about agents which can be anticoagulants, and there are several, antiplatelet, which are several as well. So the problem is really very, very heterogeneous and not simple one. Theoretically, one can think about several possible solutions to the problem. One can think to ignore absolutely thrombocytopenia, take the risk and give full anticoagulation or full treatment with antiplatelet. On the other hand, the opposite, one can avoid this treatment, at least temporarily, in setups such as transplantation or post-chemotherapy, with the hope and the expectation that the platelet will rise at least to the level of 50,000. We can give platelet transfusions. We can even decide to raise the threshold for platelet transfusion at about the 40, 50, and to maintain the patient in this level. Not easy, not simple, but one can consider. I'll refer to that in a minute. One can modify the dose of anticoagulation or antiplatelet treatment, but what do you mean by modification? Is it reduced dose? How much reduction? 20%, 50%? Temporary or permanent or intermittent use? We can think about thrombomimetic TPO receptor agonist. I'll say something about that. We can change the anti-MDS treatment to treatment which will cause less thrombocytopenia, or we can treat the cardiovascular disease, for example, in Watchman, in a way that will make thrombocytopenia less critical. And don't forget that we can use antifibrinolytic to minimize the bleeding. So these are the possible solutions, and I would like to say what we know about them. What do we know about thrombocytopenia in MDS and the possible treatments? Well, what about platelet transfusions in this patient population? We in the European MDS group have decided to review the literature, and we published about a couple of years ago in the net, you can find it under the term MDS Europe, we published guidelines for treatment. Interestingly enough, the literature on platelet transfusions as well as the evidence is very little. We recommended that the indication will be only in active bleeding. There is no evidence to recommend prophylactic platelet treatments in any number. Platelet transfusions are recommended to be given per local guidelines. Most of us will do it when the platelet count is less than 10,000. Always don't forget to consider the thrombostatic such as tranexamic and antifibrinolytic agents such as hexacapron. Can we use thrombomimetics? Basically, the answer is yes. There are two thrombopoietin receptor agonists, TPO-RA, romiplostim, Nplate, and L-thrombopag revolate. Both drugs, either as monotherapy or in combination, have been shown both in lower risk as well as high risk MDS to be effective in about 50% of the patients. When they are effective, we are talking about increasing the platelet count, reducing the need for transfusions, and decrease the clinically significant bleeding. Also, there are a couple of reports about improved quality of life, and all this with a reasonable tolerance. This is taken from our ASPIRE protocol, ASPIRE trial, in which we show that even in very high-risk patients with high-risk MDS who are post-Vidaza and do not respond to Vidaza anymore, but are severely thrombocytopenic, you can see the lower curve represents the clinically relevant thrombocytopenic events, which was lower than the controls if they received L-thrombopag. However, two negative trials changed the pictures. One trial is the romiplastim trial initially reported by Hagop Kantarjan and then Ban-Ari Guanidis in 2014. In this trial, it was clear that the percentage of AML patients was slightly higher than the controls and the study was early terminated. Another trial, the romiplastim trial, another trial is the L-thrombopag, the support trial, led by Michael Dickinson from Australia. In this trial, we treated higher risk MDS patients with AZA compared with AZA and L-thrombopag, and the idea was to minimize thrombocytopenia. However, unfortunately, the trial was proven to be futile with no effect and with more AML patients in the AZA plus L-thrombopag arm. So the study was early terminated and the development of these two agents, unfortunately, was stopped, leaving the patients and us physicians with unmet need. So if to summarize that point, we have two negative trials, but there are several other positive trials with good results. There is also long-term evidence from our ASPIRE study, which were presented ASH last year, and the paper is now about to be submitted. There is also a recent report by the French group, showing that long-term use of L-thrombopag is safe, and there are two meta-analyses with no excess mortality. So, as I suggested in a commentary, in a recent commentary in the British Journal of Hematology, I personally believe that it's time to lift the embargo. Unfortunately, still, these two agents are under embargo, and we do not have effective treatment for the patients with MDS and thrombocytopenia. Another good news is that recombinant human thrombopoietin might come back to the game, and there is a recent publication about a couple of weeks ago in Frontiers of Oncology. An investigator team from China showed some interesting results using recombinant human thrombopoietin. Avatrombopag is another interesting agent, so far has not been used in the field of MDS, but might be in the future something to consider. So what lessons have we learned in using anticoagulants or antiplatelet treatment in patients with cancer and thrombocytopenia? So I will talk now about the trio of cancer in general, not really MDS, thrombocytopenia, and the need for anticoagulation and or antiplatelet treatment. So most of the literature is retrospective. Here we can find a paper published about 7 years ago. Researchers from Edmonton, Alberta, Canada, retrospectively reviewed their data on the use of anticoagulation for patients with cancer and associated venous thromboembolism and thrombocytopenia. They could retrieve data of 6 years of treatment. Totally, they could collect data on 74 patients and turned to be that 23% of the patients did not receive any anticoagulation, 40% full anticoagulation, 36% only partial anticoagulation. The outcomes were 31,000 recurrent VTE and 17,000 bleeding, 4% major bleeding. The conclusions were so heterogeneous the complications were frequent and the number of patients was small, so the authors could not draw any practical conclusions and recommendation from that study. Another retrospective study was more practical and was recently published in American Journal of Hematology. The investigators compared the outcome of continuing versus temporarily discontinuing anticoagulation in transplanted patients who underwent transplantation, either allo or auto, and had a history of prior venous thromboembolism. They measured the outcomes 30 days from the transplant. 13% of the patients, the transplanted patients, met the inclusion criteria, and they found that the recurrent VTE was similar in both groups, those who continued as well as opposed to those who stopped, but the bleeding, as expected, was more in the patients who continued anticoagulation. Their conclusion and recommendation was that probably if you can, try to withhold treatment with anticoagulation till the platelet rise to the level of 50,000. Another study was recently published in Blood Advances, asked the question, can we modify the dose of anticoagulations in patients with cancer and thrombocytopenia? They compared, this investigator team compared the full as opposed to modified anticoagulation. They did not really split the meaning of modification. And the patients were again patients with active cancer, acute venous thromboembolism, and platelet count below 100. Pay attention to the fact that this is really mild thrombocytopenia, which does not really scare us as hematologists. The results within 60 days were as follows. Totally, there was 121 patients. 62% received full anticoagulation, 27% modified, 11% did not receive any anticoagulation. The major bleeding was, as expected, 13% in the full anticoagulation, only 7% in the modified, and the recurrent VTE was about 6% in the full, none in the modified. The recommendation was that probably modified anticoagulation in this patient population may be okay and may be safe and should be considered. What about the bleeding risk of patients with anticoagulation and atrial fibrillation who also have thrombocytopenia? This is a retrospective joint Israeli-Dutch study which reviewed data from patients with anticoagulation, who needs anticoagulation for atrial fibrillation, having hematological neoplasms and thrombocytopenia. Here we are talking about thrombocytopenia less than 50,000. 61 patients were recruited to this study. 69% received anticoagulation. As expected, anticoagulation was associated with bleeding, 17% compared with only 5%. Interestingly, the incidence of thromboembolism was very similar, 2.4 opposed to 5.3, which was not statistically significant. And again, patients with thrombocytopenia, as expected, had higher mortality. The conclusion was that the bleeding risk outweighs the risk of thromboembolism, which is consistent with many other reports. What about the baseline thrombocytopenia in patients with cardiac disease who require cardiac catheterization? Is the thrombocytopenia risk factor? This was studied in Japan. The investigators took together 3 studies, totally almost 20,000 patients. These are not cancer patients and have nothing to do with cancer, but they took data on 20,000 patients and they look for those who had thrombocytopenia. So about 2,500 patients, 13% of these patients had thrombocytopenia. They divided the thrombocytopenia into 3 groups: mild, 100 to 150, moderate, 50 to 100, and severe, less than 50. And they followed this patient for 3 years. Again, this is a retrospective study, and the endpoints were the ischemia, and or bleeding. Most of the patients with the thrombocytopenia, 12% out of the 13 had mild thrombocytopenia. So practically, these are not really reflecting the patients in whom we are hesitating. The ischemia was common in patients with thrombocytopenia, like in the patients without thrombocytopenia, hazard ratio close to 1. But the bleeding was more common in patients with thrombocytopenia, as well as the mortality, which was in a higher rate. So the conclusion was that thrombocytopenia, not surprisingly, is associated with bleeding risk. Can we treat patients with acute MI with aspirin, as the cardiologists always recommend? So here, this is a study published by Dr. Feher about 2 or 3 years ago, in which they studied the use of aspirin in patients with hematological neoplasms and severe thrombocytopenia who develop or experience acute myocardial infarction. This was a retrospective study reviewing the data from Memorial Sloan Kettering Cancer Center during the years 2005 to, of course it is a mistake, 2005 and 2014. And they talked, especially they focused on the patients with severe thrombocytopenia below 50,000. More than 100 patients were recruited, and they found that the 1-year overall survival was shorter for patients with severe thrombocytopenia compared with the patient who did not have thrombocytopenia, not surprisingly. But the more important result was that the 1-year overall survival for the patient with thrombocytopenia who received aspirin was better, 32% compared with 13,000 for the patients who were treated with aspirin despite the thrombocytopenia. Surprisingly, the bleeding was not really a major problem in these patients. So the conclusion was that aspirin is associated with improved overall survival in patients with hematological neoplasms and severe thrombocytopenia who develop acute MI during the 7 days from acute MI. This was actually confirmed by 2-3 other reports. And this is another review which basically say the same and recommends aspirin in the 7 days, and also recommends this review that the PCI, cardiac catheterization, is safe if the platelet count is at least 40,000. If it is less, then you may consider unfractionated heparin with a lower dose. What is the impact of thrombocytopenia in patients with atrial fibrillation who undergo left atrial appendage occlusion, LAAO? We know that over the last decade, several other possibilities, such as using the Watchman device, can probably prevent atrial fibrillation in patients. And we have more and more experience. But what about thrombocytopenia in these patients? So there is a recent paper in which they reviewed the data from 2016 to 2018, patients with atrial fibrillation requiring or undergoing LLAO with thrombocytopenia, but again, relatively mild thrombocytopenia. The number of patients was relatively small, only 32, and they found that the incidence of stroke and thromboembolism was very similar, although the numbers are different, but it was not statistically significant. And again, similar device-related thrombus between patients with and without thrombocytopenia. As expected, there were more bleeding episodes in the patients with thrombocytopenia. They concluded that basically the Watchman device is relatively safe and effective, although one cannot ignore the possible complication of bleeding. So using Watchman is obviously one of the possibility in these patients with chronic atrial fibrillation who require long-standing anticoagulation. What about the new anticoagulants, the DOACs, direct oral anticoagulants? Very little evidence, but there is some. Here, this is a a recent publication summarizing data on 135 patients. 104 of the 135 were on anti-cancer therapy, and these patients received DOAC. There were no thrombotic or major bleeding, it's important to mention, only minor bleeding, and probably, interesting enough, more bleeding in patients with MDS and thrombocytopenia as expected. So the conclusion was that DOACs are probably effective and safe. I feel that at this time, we have so little evidence and so little information that it's still too early to recommend to prefer the DOACs on the old traditional anticoagulation. What about DAPT, dual antiplatelet therapy in patients undergoing cardiac catheterization who also have thrombocytopenia? This was studied recently, and these are the outcomes of these patients. This was a meta-analysis summarizing totally data from almost 120,000 patients in 8 studies. 38,000 of these patients had also low platelet count, but again, we are talking about relatively mild thrombocytopenia. The endpoints were bleeding, stent thrombosis, stroke, and other cardiovascular events, and as can expected, the bleeding was higher tendency in the low platelet count compared with the patients with normal platelet count, and again, higher mortality, but similar thrombosis. So yes, DAPT can be used, but the bleeding again is higher in patients with low platelet count. So in summary, what one can say, and given the time as well as the paucity of evidence, I can summarize now by saying that in 2021, unfortunately, there is still very little information, especially in patients with MDS. I think that I have, long time ago, I haven't seen for a while so many reviews on very few original, compared with very few original paper and data. The field is very heterogeneous, the evidence is very heterogeneous, dealing with all type of cancers, all type of hematological malignancy, all type of anticoagulation, extrapolation, and eventually small number of patients in each study, in most of the studies, and yet they are mostly retrospective. So it's very difficult to draw practical conclusions in that setup, and unfortunately, there are more questions than answers which remain open. However, one of the few conclusions that one can draw is that probably platelet count of more than 50,000 appear to be safe. The thrombotic risk is relatively lower, especially if we talk about non-acute venous thromboembolism, catheter-related venous thromboembolism, and atrial fibrillation, especially those with lower risk and relatively lower CHAD score. And yes, the bleeding is almost always more incident and more common than the thrombotic complication. So can we draw practical recommendations? Very few. I should say that we should continue to consider in every patient on case-to-case basis the indication. We should consider the risk of thrombotic as opposed to the bleeding risk, the benefit-risk ratio. We should continue to consider the patient preference, the age, the MDS status, the level of the platelet count, and if it's possible, let's try to give a temporary treatment duration if it's possible, especially if the platelet count is low and is expected to rise. And yes, still in 2021, and probably this is a good idea, there is no replacement for good clinical and personal judgment. I have to apologize that I cannot give more practical and better recommendations. I believe that the future will be better. We need more effective and safe agents. We need prospective trials in large numbers to focus on homogeneous patient population with a single indication and single drug, and we need collaboration and international trial, multidisciplinary, and heme together and collaboration of hem-onc people with coag people, cardiologists, neurologists, and other, and to use tools, new tools of artificial intelligence. But I'm sure that we can make it, and I'm sure that the future looks better. And I think I'll stop here, and I'll be happy to take questions. Thank you again for inviting me. Thank you, Dr. Neimer, Dr. Cazzola, Dr. Buchstein, and the MDS Foundation, and hope to meet you face-to-face next year. Thanks.